my name is Claudia Rivera. I'm a rheumatology nurse practitioner from East Lansing, Michigan at Pine Hollow Partners. And today we're going to talk about when should a steroid-sparing agent be considered in polymyalgia rheumatica management and what options are available. So typically patients will get started on 20 milligrams prednisone when they're thought to have polymyalgia rheumatica, but I have seen as high as 60 to 80 milligrams prednisone from emergency room or even primary care. So we know that long-term steroids are dangerous for patients and can lead to things like osteoporosis, diabetes, adrenal suppression, increased infection risk, obesity, poor wound healing, and a lot of other issues. So guidelines recommend reduction of prednisone by 10 milligrams every 2 weeks until you get to 20 milligrams prednisone. Reduction after that, 2.5 milligrams every 2 to 4 weeks until you get to 10 milligrams prednisone, and reduction by 1 milligram every 4 weeks as long as no relapse. So a lot of times we do end up having to increase the dose of prednisone if the patient has symptoms that return. Sometimes they're doing okay and then they flare, so we have to go back up a little bit, maybe a milligram or two, and then try to slowly wean back down the prednisone. So typically, polymyalgia rheumatica, just on steroids and prednisone, can take 6 months to 5 years or even more for patients to be able to get off of the steroids. So when should we start steroid-sparing agents in polymyalgia rheumatica? So typically when there is a glucocorticoid dependence, so the patients cannot taper off of the prednisone below 7.5 milligrams a day without recurrent flares. Also when there's relapse of the disease. So when there are multiple flares during tapering or even after discontinuation of the steroids. Also, in patients that have high risk of steroid toxicity and we want to get them off of the steroid fast. So for example, these are the patients that are high risk, such as patients with diabetes, osteoporosis, cardiovascular disease, history of severe infections, and obesity. What options are available? I will say Methotrexate is the most commonly used steroid-sparing agent. Clinical studies have varied methotrexate dosage for anywhere from 7.5 milligrams to 25 milligrams of oral prednisone per week. People do use oral or subcutaneous injections in the methotrexate trials, of course, with folic acid. Most common dosage of the methotrexate is around 15 milligrams per week with folic acid. There is some data with leflunomide use and some data with azathioprine. And right now, the only approved biologic for polymyalgia rheumatica is Sarilumab or Kevzara. So, of course, we have pros and cons to some of these medications, including costs, side effects, and monitoring and the type of patients that we would use. For more information, please visit the RAP website. Thank you.